Hi, I'm Dr. Michel Makaroun. I'm a professor of surgery at the University of Pittsburgh in Pennsylvania.
I'm Dr. Bruce Perler. I'm professor of surgery at Johns Hopkins in Baltimore, Maryland.
I'm Dr. Thomas Brott. I'm a professor of neurology at the Mayo Clinic in Florida. Well, I would say certainly a very important article appeared in October of this year, just a month ago. For the first time, we've got a randomized trial comparing carotid endarterectomy and carotid stenting to medicine alone. So you have three groups out of primarily Germany, in which a little over 500 patients were randomized to those three groups. We haven't had a trial like this since the asymptomatic carotid atherosclerosis study published in 1995, or the asymptomatic carotid surgery trial published in 2004. So it's been quite a big break between randomized trials comparing revascularization to medicine. And in this trial, all three groups did well. And I think that's the first point to make. Whether it was surgery or stenting or medicine, all three groups did well with the complications out to 5 years, less than 5%, which is really impressive. The surprise, I think, was how well the medical group did. So at 5 years, the medical group rate of stroke was only 3%, which is about a third of what it was in those earlier two trials. Unfortunately, this trial had to be stopped because there was inadequate randomization. They couldn't enroll the patients. And so with only 500 patients and all three groups doing well, the ability to distinguish the different treatments was just not there because of the small number of patients and the small number of events because they did so well. So that's a big, big development, I think, in our field, which goes along with observational studies, which have shown that in the last 20, 25 years, with patients not smoking, taking statins, getting their blood pressure controlled, taking care of their diabetes, they're doing well if they get surgery, if they get stenting, or if they don't get either one of those and just take care of their risk factors. They can do well with asymptomatic carotid stenosis.
Maybe we have not stressed the point that a carotid stenosis is not a carotid stenosis, is not a carotid stenosis. Is there a way of distinguishing the patients that you believe may actually benefit from an intervention? Is it really reasonable to talk about all patients as just one group when we're talking about asymptomatic, symptomatic, the characteristics of the lesion, the age of the patient, the variety of other factors that actually influence the decision-making that we always have to do almost daily?
You know, to get to the original question, certainly one of the latest trends in carotid disease is the controversy over the management of the asymptomatic carotid patient. And as Dr. Brott pointed out, there were excellent results in that study with medically managed patients with asymptomatic carotid disease. But as Dr. Makaroun said, or implied, I think not all asymptomatic stenoses are the same. If you look at data that was published within the last couple years from the Oxford Vascular study, patients with asymptomatic disease followed prospectively. For those with greater than 80% asymptomatic stenoses, the annual stroke rate was 3.5%, in my recollection. Those with a less than 70% stenosis had about a 1% 5-year incidence or strokes. So one of my concerns about that randomized trial, which will be widely quoted, but as you said, was stopped prematurely, was that there were a good number of patients with only moderate asymptomatic stenoses. And clearly, I think they will do well with medical management. Whether that translates to the patient with 80 or 90% degrees of stenosis, particularly if they have troublesome plaque morphology, echolucent plaques, I think that really is an unknown in this area. So, I mean, clearly there's a movement to manage the majority, if not all, asymptomatic patients today. Medically, I'm not sure the data is there to support that position.
Yeah, I would agree. And I think we have the upcoming CREST trial where we'll have 2,500 patients instead of 5 patients to answer the kind of the lumping question that Dr. Makaroun referred to. A problem with dissecting out the group, which patients do better. Since they all do so well, it's very hard to prove almost anything but age with transfemoral stenting among the clinical variables that might be important, such as the plaque or ultrasound signals via transcranial Doppler. So it's tough. It's very tough to filter out those contributing factors that would allow us to separate the patients out.
But I guess we can all agree that compared to 10 or 15 years ago, we are much more likely to use medical management in a larger subsegment of the patients who present to us with a carotid stenosis. And we tend to jump the gun to an intervention a little bit less often than we used to.
Certainly in my practice, I'm very, very conservative about intervening on asymptomatic patients. I mean, they come to the office and they've been told they've got a carotid stenosis and all they can think about is stroke. And we spend an awful lot of time educating them that the plaque's not that bad and they can do very well with medical management. But there are patients with severe stenoses or stenoses that have progressed under our observation or very concerning plaque that still, I think, merit intervention. I mean, hopefully CREST 2 will help us figure out more precisely how to select those patients.
Well, I don't think either one of us surgeons on this panel or Dr. Brott actually performs TCARs themselves. But clearly, this is a huge addition to the armamentarium that we have to use when we decide an intervention is appropriate. The TCAR has shown itself to be fairly attractive, at least to some of the group of surgeons who can actually use TCAR to actually put it as a solution for the patients who may be high risk for the standard carotid endarterectomy. I guess putting it exactly in perspective remains a difficult target in the absence of large comparative trials, but clearly it has established itself as a relatively safe, if not safer, alternative to transfemoral carotid artery stenting, and almost is approaching the technical results of carotid endarterectomy. So from my perspective, I see it as a methodology that can serve as certainly a subsegment of the population that present with carotid artery stenosis and clearly will achieve very good results.
I agree with Dr. Makaroun. I would just, as he knows and Dr. Perler knows very well, the ability for the interventionist to not have to navigate the aortic arch and to perform the stenting under retrograde flow conditions where particulate matter can kind of go backwards and not end up in the brain. Those two theoretical advantages, I think, are very important. The registry data as well, which and registries have improved quite a bit over the last 20 years. I think the registry data are very encouraging with regard to the short-term safety of TCAR. What we don't have with TCAR are long-term numbers in terms of safety and durability. We have that for sure with carotid endarterectomy. And the large trials comparing carotid endarterectomy to transfemoral stenting provide excellent evidence for long-term safety and durability for carotid surgery, which we knew about, but also transfemoral stenting. The registry data is just not there for long-term safety. However, the safety is so good for the other two treatments, carotid endarterectomy and transfemoral stenting, that I would think that long-term safety and durability would be very good for TCAR as well. And now the FDA has agreed, and they have approved the use of TCAR for patients not just deemed at high risk for endarterectomy, but also for patients deemed at standard risk for endarterectomy.
Well, first of all, I have performed TCAR, and I do think it's going to have a place in our therapeutic armamentarium. I'm not completely sold or captured by this TCAR euphoria that seems to have swept the practice of vascular surgeons. And the FDA approval notwithstanding, I still think there are a good number of unanswered questions, even beyond the question of long-term results. Clearly, TCAR has been a master example of superb marketing, and it's really fueled, I think, for two reasons. Number one, TCAR has made carotid stenting a vascular surgery procedure because you have to, at least with the current technology, make an incision, and that sort of gives vascular surgeons primacy over interventional radiologists and interventional cardiologists, which I think is perhaps fueling why so many vascular surgeons, indeed maybe some of my closest colleagues, who had real reservations about transfemoral stenting and about carotid stenting in general, have now jumped on the bandwagon and are cheerleaders for TCAR. I think the other concerns are, much of the data that has been published about TCAR is self-reported data. It's a very select patient population that's been treated. To my understanding, last time I checked, the company had to approve every single case that was treated with their technology. So it's a bit of cherry picking. Whether this will apply to the population at large, I'm not sure. We really haven't had a randomized prospective trial, which I really think needs to be done. And very little, if anything, is written about the problem of common carotid artery dissections acutely as a complication of TCAR. And at least talking anecdotally to colleagues who have done a lot more procedures than I have, they have encountered that complication with untoward results. So I think there are a number of unanswered questions. And the other question is cost. There's only one study I'm aware of, I believe it was from the University of Texas in Houston, which showed that the cost of TCAR was statistically significantly higher, more than double the cost of carotid endarterectomy. And at least in the United States, when patients are shouldering an unprecedented level of out-of-pocket expenses for healthcare, co-payments and deductibles, I think that's going to be a real concern in terms of how the costs settle out for this approach. But I think clearly the results, as reported to date in selected patients by highly selected operators who have been well trained by the company, have been superb. And that's why I think it will have a place in our therapeutic armamentarium, but I'm not ready to throw out carotid endarterectomy.
We are clearly agreeing also that the results that we know of so far are pretty good with TCAR. But does it help, Bruce, that it's the same individual that can do both procedures and be able ultimately to select what they believe may be best for the individual rather than having a procedure that will have to change interventionalists depending on what you choose, and then there may be more factors entering the decision-making process. When it's the same individual that can do both, it may simplify the process, and hopefully they will select what is best for the patient, right?
Oh, I don't think there's any question that the patient is best served by seeing a physician who has all the tools in the toolbox: transfemoral stenting, TCAR, carotid endarterectomy, and medical management. And I think that's how most of us hopefully make the decision as to how to best treat the patient. And as I said, I think TCAR is going to be a significant part of that therapeutic armamentarium moving forward.
Well, I think the results from CEA, carotid endarterectomy, now date back to the 1950s. And we've got a multitude of randomized trials with carotid endarterectomy. And over that now 70-year period, the numbers keep getting better and better and better for carotid endarterectomy. And that's within single center studies, multi-center observational studies, and the randomized trials. In the carotid endarterectomy stent trials performed in the 2000s and reported out not too long ago, carotid endarterectomy results continue to be absolutely outstanding. And more recently, comparing early carotid endarterectomy within the first 2 weeks after a symptomatic event, a carotid endarterectomy was safer than TCAR. So I think carotid endarterectomy is still the #1 therapeutic intervention on the block based on all of these studies. That's short term. Long term, carotid endarterectomy patients do very, very well. And with all the trials, particularly with asymptomatic disease, and with 70-year-olds averaging mortality of less than 14 years, with that extended lifespan, you want a procedure that has demonstrated long-term efficacy. So amongst the three, we have the best evidence and the ongoing improvement for endarterectomy. The big question, and I guess I would take a little issue with Dr. Perler about the best physician to see the patient as somebody who can do surgery or stenting or medicine. In the asymptomatic patient, I don't think that's true. And whether or not carotid endarterectomy has a role for patients with modest endarterectomy, well, I think one consensus we have there is that medical therapy may be shown to be equivalent, if not a little safer, than endarterectomy and TCAR.
Well, I guess my point is that the interventionalist, the vascular surgeon, can recommend, as I do probably more often than not, medical therapy for asymptomatic patients. To suggest that if someone sends a patient to a vascular surgeon, they're going to get either a stent or an endarterectomy. I think among those of us who know the literature and practice ethically, that's not going to be the case. Probably 19 out of 20 asymptomatic patients I see end up being managed on medical management. So just like patients with claudication and patients with small aortic aneurysm, I'm not trying to be disrespectful to the neurologists and internists and cardiologists, but I do think the vast majority of vascular surgeons understand that the prognosis of asymptomatic patients is better than it's ever been before, largely because of improvements in medical management. And I have an awful lot of patients I see in the office who I'm simply following with annual duplex scans and who are being managed medically. And I think I represent the majority of board-certified vascular surgeons.
So I guess the question implies a little bit more about how do we make a decision to go with one or the other? And have we reached a situation where we have to potentially consider a randomized trial between TCAR and CEA? Maybe Dr. Brott can address this since he loves randomized trials.
Well, thanks, Dr. Makaroun. The challenge is enrollment. Because these procedures are so safe and the differences among them is so small, to show a difference among these three treatments is we're going to require about 3,000 patients. And 3,000 patients randomized today is extraordinarily difficult, as the two of you know. So in the SPACE trial, they were only able to randomize 2.7 patients per center per year. And in the CREST trial, and as you know, your centers are in the trial, we've only been able to randomize 2.3 patients per center per year. Patients would rather today, as before, be advised by either one of you, well, this is the treatment that you should have, as opposed to randomization, which is still unattractive to patients and their families. So while it would be nice to have a randomized trial comparing TCAR to endarterectomy or to endarterectomy plus transfemoral stenting, I really don't think that today that's feasible in Europe, where SPACE 2 had to be shut down, or in the United States, where CREST 2 now has been randomizing patients for almost 8 years.
So we have to essentially rely on first deciding if a patient needs any kind of intervention. And that's probably where the meat of the discussion is. And ultimately, if we do that, then we have to leave it into the hand of the interventionalist to choose between carotid endarterectomy and TCAR based on the retrospective data and the registry data that is accumulating. And clearly there are some anatomic features that may help steer the surgeon towards one versus the other that make the risk of one procedure slightly higher than the other, at least based on maybe pragmatic data that is not necessarily easy to study. But that's probably where we stand right now.